Welcome to CMC Code Blue, the animated high-yield review from ICU Decision Lab. This is a clinical decision workout, not a cardiology encyclopedia. In every scene, we will identify the threat, find the mechanism, choose the first safe action, and verify the response. This independent review is not endorsed by a CN and contains no secure exam content. Start with the battlefield. The public adult CMC plan describes 90 items in 2 hours, 75 scored and 15 unscored. The published weights are 39% therapeutic interventions, 23% cardiovascular conditions, 23% non-cardiovascular conditions, and 16% monitoring and diagnostics. The percentages total 101% because they are rounded. Your highest return order is hemodynamics first, then acute coronary syndromes, heart failure, shock, valves, pulmonary emergencies, procedures, devices, major medications, and monitoring patterns. Do not spend half your study time memorizing rhythm strips. The largest domain is therapeutic intervention, and the exam rewards physiologic matching. When a question feels complicated, run one 4-step loop. First, name the immediate threat. Is this shock, ischemia, respiratory failure, bleeding, obstruction, stroke, or device failure? Second, define the mechanism. Think preload, afterload, contractility, rate and rhythm, oxygenation, obstruction, or blood loss. Third, choose the necessary action that directly matches that mechanism. Fourth, verify the response with perfusion, symptoms, waveforms, laboratory trends, and device behavior. An unstable patient usually needs rescue before a slow diagnostic detour. In the hemodynamics engine room, 4 control knobs determine forward flow. Preload fills the ventricle. Afterload resists ejection. Contractility supplies force. Rate and rhythm determine filling time and synchrony. The exam rarely wants a number alone. It wants the physiologic story behind the number. Cardiac output equals heart rate times stroke volume. Cardiac index adjusts that flow for body size. Mean arterial pressure is approximately systolic pressure plus twice the diastolic pressure divided by 3. Systemic vascular resistance represents left ventricular afterload. Pulmonary vascular resistance represents right ventricular afterload. A low output with high resistance suggests a cold, constricted state. Low resistance with preserved or high early output suggests distributive physiology. Positive pressure ventilation, body position, leveling, zeroing, and valve disease can distort filling pressures. The correct move is to integrate the waveform, trend, exam, urine output, mentation, lactate, and response to therapy. In acute coronary syndrome, infarct location and instability can reverse the correct answer. Inferior infarction with hypotension, jugular venous distension, and clear lungs suggests a preload-dependent right ventricular infarct. Avoid reflex nitrates or aggressive diuresis when the patient is preload-dependent. Support filling cautiously while pursuing reperfusion. A new harsh holosystolic murmur with shock after infarction suggests ventricular septal rupture. Sudden pulmonary edema, shock, and a new apical murmur suggest papillary muscle rupture with acute mitral regurgitation. The murmur can be deceptively soft. Sudden collapse, pulseless electrical activity, and tamponade findings suggest free wall rupture. These are not routine heart failure questions. They require urgent echo and structural or surgical escalation. For ordinary acute coronary syndrome care, remember early aspirin when safe, rapid reperfusion for ST elevation infarction, and no fibrinolysis for non-ST elevation infarction. 4 villains can steal perfusion, and each demands a different rescue. The leaking tank is hypovolemia. The broken pump is cardiogenic shock. The widened vascular city is distributive shock. The clamp is obstruction. A blood pressure target may be shared, but the correct fluid, pressor, inotrope, or procedure depends on the mechanism. Hypovolemic shock has low preload and low flow with compensatory vasoconstriction. Control the loss and replace the missing volume or blood. Cardiogenic shock has low flow with congestion and usually high resistance. Revascularization and carefully selected pressor or inotrope support are central. Distributive shock has pathologic vasodilation. After appropriate fluid assessment, norepinephrine is the usual first-line pressor in septic shock, while source control remains essential. Obstructive shock blocks filling or ejection. Pulmonary embolism, tension pneumothorax, and tamponade require relief of the obstruction. A mean arterial pressure near 65 is a common starting target, not a substitute for individualized perfusion goals. Massive pulmonary embolism produces abrupt dyspnea, right ventricular strain, and obstructive shock. Anticoagulate when appropriate and escalate unstable patients for reperfusion. Acute respiratory distress syndrome produces inflammatory permeability edema and refractory hypoxemia. Use low tidal volume ventilation, appropriate positive and expiratory pressure, and prone positioning when severe. Tension pneumothorax produces unilateral absent breath sounds with shock. Decompress immediately, do not wait for imaging. Cardiogenic pulmonary edema produces crackles or B-lines, orthopnea, and elevated filling pressure. Non-invasive ventilation, diuresis, and vasodilation depend on blood pressure and cause. Positive and expiratory pressure can recruit alveoli, but it can also reduce venous return and worsen hypotension. After transfusion, stop the transfusion first if acute lung injury or circulatory overload is suspected. TR liters, I is non-cardiogenic. TACO usually has volume overload clues and often improves with diuresis. Aortic stenosis is a harsh systolic ejection murmur radiating to the carotids. Severe disease causes syncope, angina, or dyspnea and creates fixed outflow obstruction. Aortic regurgitation is an early diastolic decrescendo murmur with a wide pulse pressure. Acute severe regurgitation is an emergency, and excessive slowing can worsen filling backward. Mitral stenosis produces an opening snap and diastolic rumble, with atrial fibrillation and pulmonary hypertension as major consequences. Mitral regurgitation is holosystolic at the apex toward the axilla. Acute regurgitation needs urgent rescue, not chronic outpatient logic. Tricuspid regurgitation gets louder with inspiration and produces systemic venous congestion. Abrupt tearing chest or back pain with a pulse differential, neurologic deficit, or new aortic regurgitation suggests dissection. A suddenly painful, pale, pulseless limb is acute ischemia. Motor or sensory loss means the limb is threatened and revascularization cannot wait. Support devices are not magic. Each changes one part of physiology and creates new failure modes. Ask what the device is supposed to change, then assess whether the patient is actually receiving that benefit. Patient first, machine second. Perfusion, power, position, preload, afterload, rhythm, and circuit integrity. The intra-aortic balloon inflates in diastole to augment coronary perfusion and deflates before systole to reduce afterload. Significant aortic regurgitation and aortic dissection are key contraindications. Timing errors can erase the benefit or increase workload. A left ventricular assist device is preload dependent and afterload sensitive. A low-flow alarm requires assessment of volume, right ventricular function, blood pressure, rhythm, obstruction, and power. Electrical pacing is not enough. Confirm a pulse or arterial waveform for mechanical capture. An implantable defibrillator treats malignant ventricular arrhythmias. Cardiac resynchronization improves synchrony in selected heart failure patients. VIA ECMO supports heart and lungs. VVECMO supports lungs. Watch bleeding, thrombosis, hemolysis, limb ischemia, and circuit failure. Right heart catheterization measures right-sided and pulmonary pressures, output, and shunts. Left heart catheterization evaluates coronaries, left-sided pressures, and valves. Before contrast, assess kidney function, allergy history, hydration strategy, anticoagulants, and baseline pulses. After PCI, watch for recurrent ischemia, access site bleeding, limb ischemia, arrhythmia, and kidney injury. Back or flank pain, hypotension, and falling hemoglobin after femoral access suggest retroperitoneal hemorrhage even when the groin looks dry. After transcatheter aortic valve replacement, watch stroke, vascular complications, paravalvular leak, kidney injury, and new heart block. No pacing spike when expected is failure to pace. A spike without depolarization is failure to capture. Spikes despite intrinsic beats suggest undersensing. Inappropriate inhibition suggests oversensing. Synchronized cardioversion treats an unstable tachyarrhythmia when a pulse is present. Synchronization avoids delivering energy on the vulnerable T wave. Defibrillation is unsynchronized energy for ventricular fibrillation or pulseless ventricular tachycardia, followed by immediate CPR. Ablation targets re-entry or ectopic pathways. Monitor for bleeding, tamponade, atrioventricular block, and vascular injury. After any device or shock therapy, reassess the patient, not only the monitor or interrogation report. For every medication class, know 3 things: why it is used, what can go wrong, and how serious toxicity is reversed or supported. Antiplatelet therapy is central after acute coronary syndrome and stenting. Premature interruption can cause stent thrombosis. Unfractionated heparin can be reversed with protamine. Major warfarin bleeding is treated with vitamin K and 4-factor prothrombin complex, concentrate when indicated. Direct oral anticoagulant reversal depends on the drug, timing, kidney function, and bleed severity. Norepinephrine is the usual first-line pressor for septic shock. Inotropes can improve contractility, but may worsen hypotension or arrhythmia. Beta blockers and non-dihydropyridine calcium channel blockers slow the atrioventricular node, but can worsen bradycardia, shock, or decompensated reduced ejection fraction failure. Nitrates can help ischemia and congestion, but can be dangerous with hypotension, preload-dependent right ventricular infarction, or recent phosphodiesterase 5 inhibitor use. Hyperkalemia with electrocardiographic change is a time-critical membrane problem. Intravenous calcium stabilizes the myocardium first, then therapies shift and remove potassium. Severe symptomatic hyponatremia requires controlled hypertonic therapy and careful avoidance of rapid overcorrection. In acute kidney injury, ask whether the cause is prerenal, intrinsic, or obstructive. Stop nephrotoxins, optimize perfusion, and trend urine output. Disseminated intravascular coagulation causes bleeding and microthrombi. Treat the cause and replace components according to the clinical problem. A major platelet fall 5 to 10 days after heparin with thrombosis suggests HIT. Stop every heparin source and use a non-heparin anticoagulant when indicated. For acute neurologic change, check glucose and last known well immediately, then activate the stroke imaging and reperfusion pathway. The Diagnostic Command Center combines electrocardiography, echo, pressure waveforms, blood gases, capnography, and laboratory trends. No single screen owns the truth. the patient, signal quality, and direction of change determine whether a number is meaningful. Level the transducer, zero it, verify the waveform, and trend the patient. Tamponade may show right-sided diastolic chamber collapse and equalizing diastolic pressures. Acute mitral regurgitation can produce a large V wave with sudden pulmonary edema. Pulmonary embolism raises pulmonary pressure and right ventricular afterload, while the wedge pressure may remain normal. Left ventricular failure often elevates wedge pressure and reduces cardiac index when shock develops. On arterial blood gas analysis, read pH first, then the primary process, compensation, and oxygenation. A sudden fall in end-tidal carbon dioxide can mean disconnection, low flow, pulmonary embolism, or arrest. Reassess immediately. Inferior infarction with clear lungs and jugular venous distension. Think right ventricular infarct and protect preload. Post-infarction murmur with shock. Think ventricular septal rupture or acute mitral regurgitation. Pulseless electrical activity with jugular venous distension and muffled sounds. Think tamponade. Unilateral absent breath sounds with shock. Decompress a tension pneumothorax without waiting for imaging. Femoral access with back pain and falling hemoglobin. Think retroperitoneal bleeding. A pacing spike without a pulse is not mechanical capture. An intra-aortic balloon that inflates too early can increase afterload. A left ventricular assist device low-flow alarm demands a patient-first assessment. A platelet fall after heparin demands a HIT evaluation. Hyperkalemia with a widening QRS gets calcium first. Septic shock after appropriate fluids usually gets norepinephrine first. Now pause the video and answer the 10 code-round questions on screen. Do not settle for a letter. State the mechanism that makes the answer correct and the distractors unsafe. A strong target is at least 8 out of 10 with a defensible explanation. When you are ready, resume for the answer strategy and study sprint. Use the answer key to diagnose your weak domain, not merely to count correct letters. A guessed correct answer is not mastery. Reteach every low-confidence item aloud. Spend day 1 on hemodynamics, day 2 on cardiovascular emergencies, day 3 on pulmonary and systemic emergencies, days 4 and 5 on procedures, devices, electrophysiology and medications, and day 6 on monitoring and rapid traps. On day 7, take a timed 75-item mock and repair only the weakest mechanisms. You do not need perfect recall. You need reliable recognition, physiologic matching, and safe prioritization. End of review.